Now, what are the adverse effects? Now, if you look at the incidence of angioedema, that was slightly better, more, but not really very significantly higher. Interestingly, if you look at the impaired renal function, then actually there was less incidence of impairment of renal function as compared to the enalapril comparator. So actually, it was better for preservation of renal function. The only problem, as we saw earlier also, is that hypotension is relatively more with RD as compared to enalapril. The incidence of hyperkalemia, contrary to what one would think, was actually lesser. The incidence of cough was also lesser as compared to enalapril. So, except the incidence of hypotension, there was no other increase. Actually, there was a decrease in side effects. Now, again, if you look at the renal safety and the hyperkalemia, then the risk of hyperkalemia associated with the use of MRAs was lower. That we know that when you treat the patient with MRAs, there is a risk of hyperkalemia. So, in those patients treated with ARNI versus those patients treated with enalapril, there was a less increase in serum potassium level, and there was a lesser incidence of severe hyperkalemia. So the amount of increase in potassium was lesser with ARNI, and also the incidence of severe hyperkalemia was actually reduced. So what are the contraindications? That if the person is already taking ACE inhibitor, you should wait for 36 hours after withdrawing it. If patient has a history of angioedema with or without the ACE inhibitor previously, not indicated in pregnancy and lactation, there is no data about it. If in severe hepatic impairment, of course, it is not to be used. Concomitant use of aliskiren and any other hypersensitivity, especially to AR. The caution is about the renal impairment. So in the renal impairment is very mild to moderate. That means the eGFR of more than 30. There is no dose adjustment required. But when it is less than 30, then you need to start with a lower dose. Similarly, in hepatic impairment, in the mild hepatic impairment, no dose adjustment required. But in moderate hepatic impairment, you need to adjust the dose. Renal artery stenosis and systolic blood pressure of less than 100. So these are the patients and the volume depleted patients where you have to be cautious to avoid any incidence of symptomatic hypertension. What are the drug interaction? Any patients who are taking ACE inhibitor or had previous angioedema with ACE inhibitor should not have it. Aliskiren we saw earlier. Now, we saw that potassium-sparing diuretics has a slightly higher incidence of hyperkalemia, but actually there is not much of an issue with ARNI as if you compare it with valsartan. The NSAIDs, if the patient is taking, one has to make sure that the renal functions are tested, and any birth control pills that contain drospirenone should be avoided.